Thanks, Mark. Always a challenge to speak after Richard Field and Richard Villa and the A-list faculty we have on the list, but I'll do my best to unravel the mystery around hip instability. And I will start by saying we're very much at the embryonic stage of understanding this condition, and as Richard Field alluded to, we'll unravel the story through generations, I suspect. I would like to thank Medacta for the opportunity to present to you all today. So I'll start with thinking about the pathomechanics. With repetitive loading and rotation, we know this can affect the muscles, the ligaments, and the bones, and there is an interrelationship between these elements when talking about hip instability. So I'll follow the history examination and radiological evaluation model during this presentation and briefly touch on conservative management and operative tools, particularly in the arthroscopic field. So when discussing the bony elements of the hip joint, we've traditionally been told that the hip joint is a highly constrained ball and socket joint, but is it really a highly constrained ball and socket joint is the question. We know the acetabulum is anteverted, and there's a range for this 15 to 20 degrees with a lateral tilt angle of 45 degrees. Proximal femoral anatomy varies, average of about 130 degrees with an anteversion angle of 10 to 15 degrees. And what we do know, though, is in the positions of hip extension, adduction, external rotation, rely enormously on the soft tissue structures to provide hip stability. When we look at further into the soft tissues, we go within the hip joint itself. We've heard from Mark Saffron that the acetabulum does cover approximately 170 degrees off the femoral head. And we know the labral width varies enormously, ranging from 3 to 8 millimeters. And in high acetabular dysplasia, this can be often much greater than this. The acetabular surface area is increased by 25% with the presence of a labrum. We know the acetabulum volume increases by 20% in the presence of a labrum. And we know the acetabular labrum performs the separation junction between the peripheral and central compartment, and with it provides a suction seal effect. And if in the presence of a labral tear, we know from work undertaken by Ferguson and Crawford that 60% less force is required to distract the joint. And we know without the labrum, when we look at our end-stage arthritis patients, we often see the femoral head extruding laterally and superiorly. So often we get this appearance of the femoral head displacing laterally. Oh, beg your pardon. So just as a arthroscopic impression of what actually happens within the joint, I was told not to press this. It should play the video, but this video was supposed to show you the kind of translation we see in the presence of a ligamentum teres tear and a labral tear. So it's just about to play now. So this is a view through the central compartment, and the legs being externally and internally rotated. So you see the massive excursion that the femoral head does travel when it's internally, externally rotating. You'll see the yellow degenerative tissue at the anterior rim of the labrum anteriorly, and this is what we're talking about, inside-out instability in the presence of labral tear and ligamentum teres tear, but we don't know which one is causing this. So when we talk about the biomechanical model of the hip joint instability, and we can go through the different structures. So when we talk about the ligamentum teres, we know Hal Martin has led the way in talking about the biomechanics. So if you perform basically a squat or a deadlift, we know we stretch the ligamentum teres maximally in length. And in this position, the ligament teres is trying to resist inferior translation and also anterior translation. And when we look at the biomechanics of the ligament teres, we know the tensile strength is comparable to the ACL. We know from Mark Pilipon's work in the lab that the mean length the ligament teres elongates to before it snaps is approximately 53 millimeters, and most tears occur with intrasubstance, although this can occur at the foveal or ischial attachment of the ligament teres. And we know the ligament teres displaces under tension approximately 0.5 millimeters per second until failure from his work. So when clinically we would assess the ligamentum teres, this is a test that we validated with John and Mike in Australia, the ligamentum teres test. So clinically I use this routinely in my clinical assessment of the ligamentum teres. Again, I think there's going to be a delay with the video. I would like to show you the ligamentum teres test. It's sensitive and specific to the ligamentum teres tears. So you fully flex the hip and you bring it back by 50%. you fully abduct the hip and you bring it back by 50%, and then you tension the hip in internal and external rotation. If you've got tears of the anterior or posterior bands, you can reproduce some pain. So we look at these arthroscopic videos. You can see when the ligamentum teres is intact, labrum's intact, then the excursion of the femoral head is relatively low. And the video on the left is showing you sort of normal excursion. There is an impingement osteophyte anteriorly, just incidentally. And that's a normal ligamentum teres sort of structure and the normal sort of excursion we would see in the absence of a tear. Can you play the video on the right, please, the other video? Now, if you look in the presence of an isolated ligamentum teres tear, and I'll thank John for this video, there's no labral tear here. This is a patient with a ligamentum teres rupture. Have a look at the excursion of the femoral head. The femoral head is almost 50% displaced, traveling anteriorly, stretching the anterior capsule and shearing the acetabulum labrum and chondrolabral junction. Can we play that one more time just to emphasize the inside-out instability concept that Richard Field talked about? Okay. So what about the other structures that may play a role in hip instability? We're all familiar with the hip capsula, the iliofemoral ligament, the pubofemoral ligament, the ischiofemoral ligament, and the zona orbicularis. If we take each of those ligaments in turn, and Hal Martin work, again, I would quote because he's looked at this very carefully and dissected each band to see what the effects of it are. And we know the iliofemoral ligament comes in two strands. The medial part of the ligament is the medial arm and has more effect on external rotation, and the lateral band has more effect on external rotation and more effect on extension and internal rotation. The ischiofemoral ligament, we know, is a primary restraint against hyperextension and internal rotation. And we know the pubofemoral ligament blends into the iliofemoral ligament medially and is a primary restraint against hyperabduction and external rotation. What about the zona orbicularis? This is the intra-articular element of the hip capsule, and we know it's the narrowest area within the hip capsule, and it limits axial distraction. We also know the zona plays a role in the dynamic circulation of the synovial fluid, and you can read more about that from Richard Field's paper that was recently published. And the three bands of the iliofemoral ligament, the pubofemoral ligament, the ischiofemoral ligament, and the circular zona together appears to form a screw-home mechanism to provide additional stability within the hip joint. In positions where the hip is unstable, for example extension, the ligamentous structures tighten and compress the femoral head within the acetabulum. And in positions where the hip is where the hip capsular structures are loose, then that often in exchange tightens the ligamentum teres. So I think the two would definitely contribute to intra-articular hip stability. What about the extra-articular structures, the iliocapsularis? A recent study reported the rectus femoris to iliocapsularis ratios and found that in development displays of the hip, this ratio was increased. In other words, the iliocapsularis muscle hypertrophied in the presence of hip instability. What about the periarticular muscles moving outside the joint? We know the muscles acting collaboratively can compress the femoral head within the hip joint, and we know that the iliopsoas tendon has a key role to play in anterior hip stabilization. So just to summarize the pathomechanics, and this is just a proposal, my view is that the repetitive forces damage the soft tissue stabilizers, i.e. the labrum, the ligamentum teres, and the capsular ligamentous structures. They increase the translational force within the femoral head, lead to increased tension and shear forces, damaging the anterior rim of the hip joint and potentially leading to early degenerative changes in the younger patients. So when thinking about the etiology of microinstability, I took this structure from Mark Saffron's review paper in the journal Hip Preservation Surgery that was recently published, and I would recommend that paper to you all. And we think about the underlying causes. So in the presence of DDH, then of course the role of osteotomy is significant, and we'll hear more about that from Fabian. In the presence of connective tissue disorders, your approach will be different to a post-traumatic hip as it will with an athletic microtrauma situation. and in the iatrogenic cause. So we really will guide our management based on the etiology. So in DDH, there's dysplasia, there's abnormal joint forces, and the combination leads to hip instability and iatrogenic changes in the hip joint, and we'll all be familiar with this appearance in our dysplastic hip patients. In the presence of femoroacetabular impingement, we've heard about how the cam lesion and the pincer lesions and the focal pincer impingement lesions can lead to levering effect and microinstability, particularly posteriorly, damaging the hip joint anteriorly and posteriorly, leading to early genital changes. In connective tissue disorders such as Ehlers-Danlos syndrome, Marfan's, and Down syndrome, we know there's abnormal collagen, and that's always going to be the case. And they can display signs and symptoms of instability, and they have an inherent instability situation. Whether it can be correct or not is debated. Post-traumatic microinstability in the presence of a knee dashboard injury that can push the head posteriorly in sports, landing on the knee with the knee flexed, adducting internally rotated. This can lead to a posterior force damaging the posterior structures. And instability in the presence of elite sports, so repetitive axial rotation and loading can lead to microinstability. We know there's case reports of iatrogenic instability following hip arthroscopy. Most of these instability cases are anterior, and we know that in revision cases of arthroscopy, often a common finding will be a defect in the iliofemoral ligament. So clinical assessment. We encourage everyone to perform Baton score. Anything above 40 would indicate hyperlaxity. Michael Lerling has recently validated a self-reported Baton score and correlates that to femoroacetabular impingement. The log roll test, anything that, can you play the video please? Lie the patient supine, roll the legs, look for the elastic recoil. In the presence of capsular injury or capsular laxity, you lose this recoil, and if the angle is less than 20 degrees, then this would be deemed a positive test. Anterior apprehension test. Fully flex your patient's hip, bring them to the end of the bed, hyperextend the hip and externally rotate the hip. Reproduction of pain may indicate anterior hip pain or anterior apprehension. The posterior apprehension test, flex the hip to 90 degrees, adduct and internally rotate the hip, and then produce a posterior force, and this may reveal some posterior instability in the hip. The prone external rotation test, you position the patient prone, maximally externally rotate the hip, and apply a posterior pressure to the greater trochanter, and this can often lead to anterior apprehension. And finally, the abduction external rotation test, position the patient laterally, extend the hip, externally rotate the hip, and apply a posterior force to the greater trochanter. Again, this can lead to symptoms of instability. Radiological assessment, I'm going to skim over because I think Fabian will probably cover this when using tools to assess the indications for osteotomy, because I think I'm going to run out of time. But I will talk about the MRI scan, and when you perform an MR arthrogram, if you look at the scan in the presence of hip laxity, if there's greater than 5 mils adjacent to the thinnest part of the hip capsule, this can often indicate that there is laxity, and if there's 3 mils of fluid at the labral chondral recess, this can often indicate there's laxity at the hip joint. Richard Field's work, when you externally rotate these hips to maximal external rotation, there appears an apparent attenuation of the iliofemoral ligament, and this would indicate that the iliofemoral ligament is not being stretched in the position when you would expect this to be maximally thinned. CT scans are useful for posterior subluxation injuries, so I'd encourage you to look at the sportsmen, particularly who have fallen on the flexed knee, and you can get a bony Bankart lesion posteriorly. Moving on to now the examination under anesthesia phase, you can pull on these legs, and relatively little force is required to produce the vacuum sign. And when you inject the fluid, you'll notice that a large volume can be inserted into the hip joint with relatively little resistance. And you can even perform a dynamic fluoroscopy looking for positions of instability during screening. And the treatment will be gauged based on the indications of surgery. Do spend time on physical therapy, particularly in Ehlers-Danlos patients or hyperlax individuals. Renal line osteotomy, Fabian will talk about. Arthroscopic management would comprise thinking about the, let's go back one, the hip capsule. The hip capsule can be treated with thermal radiofrequency probes, or it can be treated with sutures. The capsular suture techniques can be either central compartment tightening, and the limitations of this is that this technique has to be performed in traction, so the amount of tightening you can perform is limited. And if you perform a peripheral compartment technique, then you can plicate the hip more, because you don't have to apply traction, so you can probably tighten the hip capsule further. So in the presence of hip capsular dehiscence, or when the two ends can't be brought together, you may want to consider iliofemoral ligament reconstruction, and this has been reported to be performed open and arthroscopically using autograft or allograft. The ligamentum teres can be debrided with radiofrequency, or can be reconstructed, as you heard from John O'Donnell. And labral tears, sorry about this. And the labrum can be repaired. We recommend to repair the labrum, and in the presence of degenerative labrum that is irreparable, we consider reconstruction to provide some further stability. The post-operative rehabilitation protocol is really just limited at and targeted at the physiotherapists to say, be a little bit careful about these patients. They all have different protocols. I don't know which one is the best, but my emphasis is really to limit external rotation past 40 degrees to avoid stretching out that hip capsule, particularly if you've sutured it. So in summary, microinstability, we're very much at the early stages. It can be very disabling and painful for athletes, and difficult to really treat. And it's formed a focused research area in the Ischias Society now, so hopefully the story will unravel itself over the next few years. There are specific diagnostic algorithms based on the underlying diagnosis, and physiotherapy certainly has a role, as does arthroscopic management. Thanks for your attention.